This conference will now be recorded.
Things look good so far. This is John Antonucci and AnCan's high-risk metastatic advanced prostate cancer discussion group for January 28th. I'm going to take a moment to thank our sponsors, Bayer, J&J, Myriad, Telix Blue Earth Foundation Medicine, and Novartis, who help us pay the bills but don't require us to sponsor their products. We'll be talking about a number of medical issues, but don't take, we're just sharing each other's information. Don't take this as medical advice. Discuss everything with your doctors. I'm going to say a few words to the new guys. There are several new guys on the group tonight, at least 3. And what we do is, as you've seen, I'll take sort of inventory, see who has questions that they want to bring up. We'll spend the first hour or so on the new guys, collecting basic information if you're willing to do that on your very first visit, and seeing what questions you have so we all can get to know you. After that, we'll go down the list and try to address everybody else's questions. We have a great many people here, so we're going to do our best to get to everybody, but if we don't, just write to me afterwards, Dr. John at ancan.org, and I'll try to catch up anything that we might have missed. I'm going to start by talking to John Maxwell.
Yes, I'm here.
If it's okay with you, John, I'm just going to ask you a handful of questions so we can get to know your story, okay?
Go for it.
Another thing I want to do is to change my view to the people that are also on the phone so I don't miss anybody on the telephone. Okay, I don't think we have anybody on the telephone. Okay. John, how old are you?
I am, well, effective 64.
Where do you live?
I'm Chicago.
When did you get diagnosed, John?
Was initially diagnosed with 1 core of Gleason 7 in June 2023. It was actually 10% of 1 core. And then I was diagnosed in December of 24 with 2 Gleason 8 cores and 1 Gleason 7 core.
Or you had another biopsy?
Yes. I had a biopsy in December of 23 that found nothing. So I've had several biopsies, but the most recent one in December was 2 cores of 8 and 1 core of 7.
Okay, and your 8 was presumably a 4+4.
Yes, it was, yes.
Are there any other comments on your
7?
biopsy?
And you 7, was it a 4+3 or 4+4?
I had a 4+3 and a 4+4.
Okay, thank you.
In December. Anything else in my biopsy? No, no.
Just adenocarcinoma, no penetration through the capsule, no evidence of invasion of the seminal vesicles, no cribriform pathology, no interductal pathology, just straight adenocarcinoma 4+4.
There is potential, hold on a second, for penetration beyond the capsule. That is suspected.
Okay. And then after your 2024 and no treatment in between those biopsies, right?
No treatment whatsoever. I'm awaiting the next step in the process. or shall we say the first step in the treatment process.
Okay. Now, now that your cancer has advanced to the point of having 4+4 and maybe pushing the capsule, has any further diagnostic work been done, such as genetic tests, MRI scans, PET scans?
We did a PET scan, and the PET scan revealed nothing beyond the prostate.
Excellent. Okay. No MRIs?
I had an MRI that preceded. Let me see. I had an MRI in October that showed the prostate was lit up with contrast, but nothing else, nothing in the bone, nothing in the lymph nodes. Then we did the targeted biopsy, which came back with the 8.8 and the 4.4 and the 4.3.
Okay. The MRI helped you find that 4+4.
It did. And then did the PET scan, which showed nothing beyond beyond the prostate, although there's suspicion for margins, for positive margins.
Okay. What about gene tests? Any of that?
Um, did a oh
Cipher?
yeah, did a decipher, and the score on the decipher, and I didn't get the full decipher as I've heard from other people, but the score on the decipher was a 7, which is high risk.
0.7. Okay. Very good. And you haven't sent off any color genetic testing or any of that kind of thing, right?
None of that yet. None of that yet. And I'm waiting for a date to do a prostatectomy at this point, and that seems to be what the consensus is. Our next step should be.
Tell us what your PSAs have been like.
My PSAs going back a decade were always a little bit high. Back 10 years ago, I had an 11, got on finasteride, it came down. In 2022, it was 4.2. In 2023, it was 4.3. Then in May 2024, 7.2. In September 2024, 9. In November, it was 10.6. And in January of this year, 12.5. So rapidly rising.
All right. Do you know the size of your prostate?
Hold on, John. Hold on, John. Were all those numbers on finasteride from?
All of those numbers are on finasteride.
Thank you.
Okay. What was your question, John?
Oh yeah, I was wondering about the size of your prostate. Did they give you an estimate on
It
that
was
MRI?
28, I think, or 29.
Okay. Okay. So your PSA is now 12.5. How far back do we have to go before we have a PSA of, say, 6 or 7?
7 was in May of 2024. So basically 8 months later, it was at 12. And all those are under finasteride. So it's a doubling time, right?
Yeah, so you're maybe roughly a year doubling time, but we have to take into account that you're on finasteride, like Rick pointed out for us. All right, very good. So now you're on nothing, no meds. You have never been on any kind of ADT or any kind of meds. You're just about to step into the treatment phase. And you're joining group to share your experiences, see what our experiences were. Do you have any questions? Do you wonder about whether to have the RP, or have you already settled that in your mind?
So first of all, I'm here because let's say I'm lost deep in the woods, and I see some of you as guides. So I'm early in the process, and it's been an emotional roller coaster. right?
Yeah.
I did a fair. By the way, I want to call out Mr. Don Rogers. Thank you, Don. Don's been a wonderful mentor to me and will continue to be. So thank you for
Great.
that.
Great.
I did a lot of talking to a lot of doctors, and it seemed like everybody, when I talked to the radiologist, they said that the right path is radiology, right? When I talked to the surgeons, the right path is surgery, right? But I'm very confident. I don't want to say doctors' names at this point, but
Go
I'm
ahead.
really
No, we're good with doctors' names. We have to share our experiences.
well. I'd rather not share his name yet until we've had the surgery, but he is a very prominent urinary oncologist in Chicago at a major hospital. In fact, the head of urinary oncology. So
Okay.
he's a pretty good guy.
Are you? I know you're uncomfortable doing so, but it's really important that we know. If you're at Northwestern, then you're dealing with a man who's the head of oncology, of urological oncology, who has a serious bias.
Well,
And
the person I'm
and
working with is at the University of Chicago.
okay, at Chicago again, we're familiar with a lot of these doctors. So it's your decision, but we would encourage you to share names only because we have people who have seen them and it's helpful. But if you would prefer not to, again, we deal with a bunch of guys. We deal with Egner a lot. We deal with
Okay, the guy I'm talking to is Egner.
okay. So Egner's a great doc, and he knows AnCan very very well. Um,
Thank you for that, Rick. That's very encouraging.
okay. Um, but there's another issue. I'll let John finish, and there's another issue that we would encourage you to do that he may not have done yet. So go ahead, John.
Okay, go ahead, John.
Are you a vet by any chance?
I am not.
Okay. Um, okay. Now, do you have a family history of any cancers?
My mother had breast cancer.
Okay. Does anybody know, does Decipher look at BRCA? Okay. Okay. Um, Go ahead, Rick. Let's get into the weeds here for a little while and with
So
John and tell him what we think.
okay,
Go ahead.
so again, how many positive cores in total did you have in the biopsy from 1224?
3.
Three. And um, was that a transperineal or a transrectal biopsy?
Transperineal
Oh,
targeted biopsy.
okay, it was a TP targeted. And um, do you know how long those cores were? Was there a significant amount of cancer? Were there how many
It
millimeters?
was. It says here 15 millimeters on the left side, nothing on the right side.
So was it all one? Was it all from one targeted area that these three cores came?
Um, I think the answer is yes because he was targeting the area that was identified by the MRI.
He also got cores from the other side of the prostate. You did all your cancers on one side?
He took cores of the entire prostate, but only cancer on the left side.
Gotcha. Okay.
And where on the left side was it? Was it base or was it apex or was it in the middle?
Um, I don't have that data.
Okay, it should identify it by the side of the core. If you're looking at your biopsy report, it will tell you where in the prostate they found it. The reason
Go
the,
ahead.
the reason we're asking is because cores that are in the base or are on the periphery, which it sounds like yours is, if there's a concern about it having gone through the capsule, are more troubling than if they're in the apex.
So I think it was in the base, and it's up against the capsule.
Right. So here's what we would ask you to do. Maybe somebody can put this link in. Have you run the Memorial Sloan Kettering nomograms yet? Or has Dr. Egner pointed you to them yet?
No.
Okay. So let me just talk about my situation as an example. I was diagnosed at age 56 with, I think it was 5 cores from a fusion biopsy, transrectal. This is many years ago. And I wanted to do surgery. The first time I walked in to see my urologist, he handed me the MSKCC nomogram. And we'll put the link for that in the chat window for you momentarily. The chat window, by the way, are the 2 little boxes on the top on the right. There's usually a lot of chatter going on in there
Thank you.
throughout the meeting. And you can click on those links. They'll open in your browser. You don't have to worry about copying them down. Now, the Memorial Sloan Kettering nomogram for pre-radical prostatectomy gives you an indicator of how likely it is that you will have a recurrence within a certain period of time. It's a large database. It's been collected over a long period of time, and it may not be as accurate today as it has been in the past because techniques have changed. We now have PSMA scans. I'm assuming your PET scan was a PSMA scan. Things have changed, but it's still a very good guideline. When I put in my numbers and I ran the nomogram, it told me that there was a 70% chance I was going to need radiation and hormone therapy after my radical prostatectomy was done. It didn't say radiation hormone therapy. It said there was a 70% chance that the cancer would be outside the capsule.
Okay.
And from that, I deduced that I would need follow-up treatment.
Yes.
And so I decided that maybe I wasn't such a great candidate for surgery, because if I went through surgery, I was also going to have to deal with radiation and hormone therapy anyway. So should I really bother with the surgery, or should I go straight to radiation and hormone therapy options? Which is what I chose to do. Now, we tried, and this is back in 2007, we tried to evaluate what the marginal benefit would be of adding the surgery. And there's really nothing that's ever been written on this. The best that we could do was go to probably one of the best doctors in the country, Dr. Peter Carroll, who's a generation ahead of Scott Egner, and ask him for his experience. And what he said was, if you add the surgery, probably you got a 3 to 4% better chance of getting everything than if you don't add the surgery. And I said to myself, you know what? I'm not interested in rolling the dice for a whole additional set of comorbidities. I'll just go with radiation and hormone therapy. I did 2 types of radiation. I did the hormone therapy. We can discuss that with you. We won't have time today, but another time. But I think that what the take home from you joining this meeting is that you have to drill down and establish how likely it is that you will need more treatment afterwards. And if that is significant, then you can decide whether you still want to go ahead with the surgery or whether you might be better with an alternative form of treatment.
First of all, thank you. I really appreciate the insight. Will the nomogram ask enough questions to understand in sufficient detail to give a meaningful answer?
I can answer that. It's based on a very large database, but as Rick said, there are some uh, modern indicators that it will not be there. But if you get uh, a very clear-cut kind of spectacular result like Rick did, then I would go by it. So if you would go to the MSKCC nomogram for post-prostatectomy, if you have any difficulty, write to me and I'll get online with you and we'll do it together. And we'll see whether it confirms your decision to have surgery or whether it casts doubt on it.
My Decipher report, which I'm looking at right now, and at the bottom it says risk estimates for this patient with standard therapy, right? Whatever that means.
Yeah.
The
That means
risk,
what are the chances that are in 5 or 10 years, I think it's 5 years, that you will have a metastasis?
it says risk of metastasis with standard therapy, 5 years, 6.6%.
Yeah.
10 years, 12.5%, which I thought was fantastic. Is this are these statistics at the bottom of the Decipher report meaningful?
Yes.
So this is saying that I have a relatively low chance of metastasis.
Yes, low but not zero.
Yeah,
Okay.
but John, it doesn't take into the Decipher is not going to take into account that you're butting up against the wall.
The capsule, right? Okay.
That's right.
It doesn't know that,
Right.
and we don't have a way of telling it that. So yes, it does, but I don't think it's complete. Now, Dr. Egner can go through this with you, and my guess is you're going to get a much higher percentage response. At the same time, if you only had 3, how many? They will ask you how many cores were taken in total.
I think there were 12 or 14 cores total.
Okay, so if you've only got 3 out of 14 cores, that's going to reduce your risk because you only have one place they're looking at. But there's a lot of factors, as you know, to take into account. But I would do everything I possibly could to establish the likelihood that you're going to need additional treatment. Len, what would you say on this?
I mean, I don't have anything to add to what you said, Rick. I agree with everything. What he does have apparently going in his favor is that it's only on one side of his prostate, right?
Yeah, except if it's in the base and it's budding up, then there's also the possibility that it could have gotten into the bladder.
Yeah. Of course, when it comes to a choice between prostatectomy and radiation, I'm with you on that, Rick. With a Gleason 8 or higher, I think the likelihood of a cure just from surgery is not particularly high, even though the nomogram would seem to refute that. But I personally would choose radiation.
Interesting. By the way, thank you very much for all this insight. I didn't come into the call expecting that. Any other points of view on this?
There are a
But
couple of people with their hands raised. I'm going to see if they have any comments. And then I'm afraid I will go on to one of the other new guys. But if you can come next week or call us, we'd be glad to talk more. But run that nomogram. We're all interested to see what you got. I've got Jeff. I thought I had two people with hands up. Jeff.
Yeah, just mention that recent studies have shown that the results are pretty much the same whether you have radiation or surgery. That's just what the long-term results have been in a recent study. You've got to realize that if you have surgery, you want to have a nerve sparing if possible. If you almost always are going to have an erection problem after surgery, which after radiation you may not have right away, or you may or may not, but it's less likely of having it. And just something to think about.
thank you.
Yeah, but Jeff, that again, that's too much of a general statement. I mean, it's true for most people if they are low intermediate. But once you start talking about high risk, with the situation that John has, whilst the outcomes may be comparable, those would be the outcomes with follow-up surgery, with follow-up after the surgery. And you're not taking that into account. For a high-risk person, there's a much greater likelihood that there's going to be recurrence. And if there's recurrence, that's going to require radiation and surgery. And the studies that you're looking at are not focused on those men who are high risk. It's looking at largely at low and intermediate risk for those same outcomes.
Are there any other comments for John? Artie?
I was about to say, but I guess Rick answered it because I didn't know about the high risk. So I was low risk, intermediate when I first got my diagnosis, and I did have the surgery. And what happened was, after the surgery, I guess some of it leaked out in my lymph nodes, and I had radiation, 35 treatments, and then I had 2 years of hormone treatment. But and then after about 8 months, it came back. So that's what happened to me. I didn't know about the high risk stuff that Rick was talking about. I just know exactly that's the route I went, what happened to me. And I have it, and now it's rising back up again. So that's what happened to me.
Julian, last word, please.
Did you get a second opinion on the biopsy?
I did not. Is that warranted?
In some
Yes.
cases, it wasn't my case because I had one doctor review it, and he jacked it up actually from 4+4 to 4+5.
The
Okay.
reason that we do that, John, what we do is sometimes, especially when it will affect the treatment plan, is we have the urologist send your biopsy sample off to an expert genitourinary pathologist and confirm the reading. If you wish to do that, we'll put some information on how to do that in the chat.
Thank you. That would be wonderful. Thank you.
Let us just tell you so you'll know what you see. There are two doctors to consider in our view. Dr. Zhou, who's at Mount Sinai, and the man who trained Dr. Zhou, Dr. Epstein, who is just back in business after a 2-year absence. And we will put his email, and we'll also put Dr. Zhou's email in there for you. And we would strongly recommend, it's a great point by Julian, strongly recommend you get a second opinion. If you were downgraded to 4+3 from 4+4, that could also have a very significant impact on your treatment decision.
Yeah.
Got it. Wonderful. Amazing. Okay, I'm definitely going to do that. This is amazing. I can't say enough. Thank you, thank you, thank you. And I will reach out to you individually, Rick and John, if I have further questions. Thank you so much.
Okay.
Um,
Stay in touch with John. I mean,
yeah,
Don.
Don, of course, yes.
yeah. Stay in touch with Don. Direct your questions to Dr. John. He can hook me in if you need me because I am so slammed because I run the whole show here at AnCan, which is
Got
a
it.
lot
Thank you
more
very
than
much.
you're looking at. Do we have your email address? Have you signed up? And that's true for all the new men on here. We want to make sure you're signed up to get our reminder.
I will send my email over to you as well.
Yes, and any other new men, and we will make sure. I also want to give a quick, actually, better John gives a quick commercial for Men Speaking Freely in case any of these men want to come here, John. You can let us know. But do you want to
John,
just?
we have a group on 2 Thursday afternoons per month called Men Speaking Freely, where we talk about the emotional side of things, and this has refers to the emotional roller coaster that you've been on. If you want to talk with us about coping, you're welcome to come to group.
Very good. Thank you. That would be delightful.
Bill Allen, you get the idea now what we're up to?
I get the idea what you're up to. It's very impressive. Thank you, and
How old
thank
are
you.
you, Bill?
Thanks for making a little time for me. Quick sort of headline here.
Oh, tell me quickly, how old are you?
I'm 67 years old.
Just going to get some of the basics on. And where do you live?
I live in near Portland, Maine.
Okay. And Rick, before you came, Bill said that he's going to be looking for ideas about who to see up there.
Okay.
I think he probably should go down to Boston, but we'll see. Bill, when were you diagnosed?
I was diagnosed in December of 2020.
Okay. And tell us about your PSA and biopsy findings.
Yep. PSA has gone from 2.4 at the end of 2019 to a finasteride adjusted 9.2. So that would be 4.6. So just double it, 4.6 times 2 today.
And did you have a biopsy back in 2020?
I've had 4 biopsies.
Wow.
Yeah.
So between two guys, we're talking about 7 biopsies or something like that. Wow.
Yeah, it's a lot of fun.
In the interests of time, because we're unusually squeezed today, tell us about your very most up-to-date diagnostic information.
Gleason 3 + 3 = 6. Number one, PSA density now is 0.41.
Let me stop you, Bill. Do you have any high risk features? Because this may not be the right group for you.
I do, actually.
Please tell us.
Yeah. The Decipher came in, and this was just earlier, actually this month, 0.91.
Wow.
In the context of a Gleason 3 + 3. Yeah, family history.
Yes, it
Let,
must
let
be
me just
positive.
let me just stick on this a second.
Yep.
Decipher 9.1 means that it's likely to spread, but that still still may not be the right group. The right group for you may still be low intermediate. You have 3 + 3. Is that correct?
That's correct, over 4 biopsies, and
Over
I did
4
get that
biopsies.
second opinion. Yep.
Is there any? Have you ever had a PSMA scan?
No.
No. I mean, there would be no reason for you to have had a PSMA scan.
No.
The problem is that whilst the Decipher says it's likely that you need treatment, you're not a high risk man. high risk is your PSA isn't high enough.
Yep.
Your Gleason score isn't high enough.
Yep.
Now we can take care of you because we have an active surveillance. How many cores positive do you have?
5 out of 15.
Okay. So we have a guy, for example, on active surveillance right now who's 11 out of 12 cores with 3+3. But he's still doing active surveillance.
Yep.
And there's a very strong philosophy now amongst the modern up-to-date urologists that as long as you're 3+3, you are still qualified for active surveillance. You don't have a 4 in your number. That is a conversation that you should be having with our low intermediate group, Dr. Mark Perlow, and possibly
Okay.
our active surveillance group. And so I would say, and you're very welcome to stay in this group and to listen, but I would say that this is not the right group for you, Bill. We would welcome you back. But
Okay. Well, I'm happy it's not the right group.
I
Yeah,
am too.
they are
be
a group you don't want to be a member of.
No, this is a distinguished but unfortunate group.
Yes. Now we can help you in that group with recommendations of really good docs. They will be in Boston.
Yep.
But we can send you to the right docs in Boston who are not going to rush you into treatment, who are going to work with you, et cetera, et cetera.
Perfect.
But if you have a long history of 3+3, albeit that's what the Decipher says, have you ever done any genomic testing? Have you germline testing, genetic testing? Have you gone to Promise?
No, I haven't gone to Promise. I'm Deciphers as far as I've gotten.
Okay, so what we would want, do you have you said you have a family history of cancer?
Yeah, father had Gleason 9.
Okay, so there's a possibility that there may be some genetic stuff going on, but until we see that and know and hear what it is, then you're not high risk.
Okay, great. Which so I don't take any more time because things are a squeeze. But thank you very, very much. And
Yeah,
I'll go ahead and get registered and then figure out which group it's. You said Dr. Jeff Perlow?
Dr. Mark Perlow, who
Perlow.
runs the low intermediate group, they unfortunately met last night. They don't meet for another 2 weeks. But we do have an active surveillance group that will meet next week, and they will have a bunch of good information for you. And I would, even with your 9.1 Decipher, I would suggest. And John, do you think that Bill should get that grid report or not?
Boy, that's a really good question. I think that there must be something genetic found on that original
Yeah.
Decipher report, or somebody with his qualifications, if you will, would not get such a high score.
Right.
Therefore, I really do think that getting that free color test would be a good idea because there's something genetic going on there that kicked your Decipher score up.
For worries me.
I think it's premature to advise the grid. It's medically not ready for prime time to be advised to patients yet. However, I have to admit to a burning curiosity and would love to see it. What we're talking about, guys, is Decipher is a test with a fairly small sample, less than a couple of dozen genes and a couple of clinical characteristics to predict if you're going to need further treatment to prevent metastasis. But there's a new, not that new, but there's a much more extensive so-called grid report coming out of Decipher nowadays that that Rick is talking about. Rick, do you want to just put a something about a referral for him? Because that seems to be what's uppermost on his mind in the chat.
Well, the first thing I want to do is put the promise link in there. So you have that, Bill. I just put it in the chat. So you'll click on that, and they will do a germline test, which is to see if you've inherited any mutations.
Okay.
Secondly, put it in the chat or send it to me, whichever is best for you, your email address, and we'll sign you up for the low, intermediate, and the active surveillance group so you know when those meetings are coming. In terms of the right urologist at Dana-Farber, which is probably where I would go, I'm not sure. I need to look at their list, and I may not be the best person to answer that. It may be that we have to ask one of the guys from low intermediate. I'm not as good. I know the GU medoncs, but and I know the radiation oncologists, but I don't know the surgeons that well because we don't usually deal with them in this group.
Yeah.
But I will look and see whose name sticks out to me. I'll take a quick look right now, and I will put it in there. You're not really a referral to a GU medical oncologist at this point.
Right.
You're really a referral to a urologist, a urological oncologist, a urologist who specializes in cancer, who is empathetic to active surveillance and will encourage you to do active surveillance unless they feel that you need treatment. And if you do need treatment, a doctor like that is going to work with you with both radiation and surgery if we get you to the right doctor.
Great.
I'm
Thank
going
you.
to I'll send an introduction to the low and intermediate group guy
Okay.
for you in case you show up in a couple of weeks. And if you do go to Dana-Farber, make sure it's a urologist that specializes in cancer. They probably all do at Dana-Farber, but it's okay. I'm going to move on to Lee if he's
very
still
much.
here. Lee, are you still here? Lee?
I am. I just needed to turn my mic on.
Oh, okay. How do you do? Welcome to group.
Thank you.
Want to give us a little rundown? How old are you?
I am 81.
Where do you live?
I live in Baltimore.
And when did you get diagnosed?
My formal diagnosis was in the fall of 2015 when I wound up in a emergency room, unable to urinate for several days. And after they drained a couple of liters with a catheter and did a PSA that came back 82, they sent me over to urology the following week, where I met with Ted Schaefer, who I'm sure most of you know is now at Northwestern. He was a resident at Hopkins at the time. He did a biopsy. I'm looking at a recent summary. Gleason was at highest was 5+5 at the right base and 5+4 throughout the right side with perineural invasion, and that was biopsy was read at the Hopkins lab, so there wasn't much question about what it was. Schaefer sent me to radiology. I did a couple of second opinions with a couple of medical oncologists who essentially all agreed that radiation was the way to go. At the time, Phuc Tran, who now I think heads prostate radiology at Maryland, he was at Hopkins. I did 8 weeks of radiation to the prostate, followed by 2 years of Trelstar, and my PSA dropped to Hopkins undetectable, which is less than 0.1. That went on for about 2.5 years when PSA started rising. I then, by just happenstance, wound up at University of Maryland, where they did 3 treatments of I had an Acumen, and then the Pylarify PSA was just approved. I had the University of Maryland's first one. They found 5 metastases in the sternum and manubrium. They were shot with 3 treatments of radiation, which from scans killed the radiation, but my PSA kept rising. At that time, I treated with Arif Hussein at Maryland, who put me on Lupron, abiraterone, and prednisone, and I have been there since it was either 2020 or 2021, where I still am. I have recently shifted treatment over to Hopkins, where I'm now seeing Sam Denmead. I don't have any pressing questions for you guys that are immediate for this week or next week. I'm looking to ameliorate some side effects from that treatment. And one of the reasons, although there were a couple of others, that I switched over to Hopkins.
If I'm in a meeting, okay? Leave me alone.
What?
Guys, please, can you mute if you're not talking?
I got him. I got Artie, Rick.
I am talking. Can you hear me?
Yes,
Yes,
go ahead. Go ahead, Lee. Sorry about that. This is you're really making an excellent presentation, giving me a lot of information in a condensed form. So you're still on ADT, still on abiraterone. Got
Yes.
Dr. Denmead. Did you have any genetic tests of any sort?
I did the promise. They came up with nothing. My father had prostate cancer many years ago. I know he was treated possibly with some sort of radiation seeds. And it went into remission, and he died many years later of Alzheimer's complications. So there is there's a history of prostate in the family. My presentation is concise because I've heard a lot of your questioning here. I knew kind of what you were looking for, and I was 30 years as a lawyer, so I'm skilled at distilling information.
You were really fast. And you'll forget it all by tomorrow, right?
I'm sorry, I didn't quite hear you.
Are you a veteran?
No, I am not.
Okay. And did Dr. Denmead or any of these doctors ever send your biopsy off for genetic gene testing?
Yes, there was an effort to do that sometime around 2019, which was 4 years after, and unfortunately the samples had deteriorated to a point where they could not sequence them, and so that information is lost.
So now your question for us is about tolerating treatment, it sounds like. So tell us what you'd like us to help you with.
I'm not ready to make an imminent decision. I'm looking at the possibility of a vacation, and to do it or not. Dr. Denmead seems slightly encouraging, but mostly ambivalent on that. Frankly, I feel generally pretty good. I get hot flashes in my legs that keep me up at night. It's a struggle to maintain muscle mass and fight fatigue. But for an 81-year-old guy who's been fighting cancer for 10 years, I'm in pretty good shape.
Yes, it sounds like it. Do you have, how long has it been since your PSA was above the threshold?
It started to rise in 2020. and we probably would have been early 21. Immediately after I went on Lupron and abiraterone, it dropped like a rock.
Well, that's a really good question about whether you deserve a treatment holiday right now. Going against it is the fact that you're metastatic and started out as a 5.5 Gleason. Going for it is the fact that you're almost 4 years non-detectable and having side effects.
The side effects are not debilitating.
Not
Life
debilitating.
goes on. We travel. In the last year, we've been to Europe. We've been to Africa. We're planning to go to Peru. So it's not as though my side effects are greatly impinging my life.
I see that our moderator Len has just turned his camera on. He's probably expecting one of us to ask him a question now because he's our guru when it comes to treatment holidays.
Okay.
You want
I'm
to
all
make a
ears.
comment, Len? How you would see this situation?
I'm a Gleason 9. I've been on a number of drug holidays over the years, which is about 10 plus years. At your age, Lee, and 4 years of undetectable, and I don't want to be the bearer of bad news here, but it's very unlikely that your testosterone levels will recover. So you're likely to continue to have side effects that are related to low testosterone, whether you continue your hormonal therapy or stop it. So that's a personal choice that only you can make as to whether or not you want to stop and see what happens. It's amazing that as a Gleason 10, you're still hormone sensitive, so you've got that going for you.
Yeah,
If
it's
you
wonderful.
stop now and things start to reverse, and probably if you go back on hormonal therapy, you'll still be sensitive.
Let me pose this question. Does stopping have any effect on whether I remain sensitive or go resistant?
I don't believe there's any evidence one way or the other. I've heard oncologists argue both sides of that. Some will say, well, whatever resistant cells you have, you've had them from the very beginning, and they're just now emerging. Others will say, well, the longer you're on hormonal therapy, the more likely it is that your cancer will morph into something more virulent or more resistant. So pick your poison there. I don't know.
It seems like every question I ask, whether I come here or talk to one or another medical oncologist or do searches on Health Unlocked, comes up with on the one hand and then on the other. It keeps reminding me of the old Harry Truman quote of every time I talk to an economist, he tells me on the one hand or the other, and I'm looking for a one-handed economist. Maybe I'm looking for a one-handed medical oncologist to tell me. But my guess is it's going to be tossing a coin at some point.
You're exactly right, Lee. And the reason is because not only now talking to us, but historically, you have had oncologists virtually on the leading edge of prostate cancer oncology. And when you're right on the edge like that, you're always going to be weighing pros and cons. If you had a really, really conservative oncologist from the old days, he'd say, no, stick with what works. Don't ask questions. But as it is, you're up to date on everything. You've got top oncologists, and so they're all going to be thinking about whether to try something new, like a treatment holiday. But you see what you get. Len's point is that your testosterone level is probably extremely low now, if not non-detectable, and it's a possibility that if you go off medicine, your testosterone will still stay extremely low. Your side effects may not change. With your testosterone level remaining low, you probably are not going to be at high risk of provoking a cancer.
But also probably not a high probability of getting the side effect I'm most interested in, frankly, is fatigue and muscle loss.
Yeah,
And I guess that's directly testosterone related.
yeah,
Well,
and you just have to keep exercising. Rick wants to say something.
yeah, there's a couple of things I want to say. I mean, the best mitigant for fatigue is exercise.
Yeah.
And aggressive exercise, daily exercise, um, at least 5 days out of 7, and a mixture of aerobic and weights, no matter your age. We've got somebody in the group right now tonight who's 5 years older than you, and he exercises regularly, and he complains that he's still fatigued, but he does an incredible job. He's a real poster boy. We'll try and get to him momentarily. What I want to say to you is this: I get very, very nervous when somebody has been on one of the second line ARSIs like abiraterone or enzalutamide for 3 or 4 years, and they have not changed the treatment. Jim Marshall, I don't think he's here tonight, did 5 years, but we see too many guys who, when they stay on that same treatment for too long, we don't know how to treat them when they fail, because the cancer gets so comfortable with that treatment that it figures out how to work around it. And when it does work around it, nothing else works. Now, that means the options for somebody like yourself, and whether Denmead would do it, I mean, we know Denmead, but whether he would do it or not, I honestly don't know, would be either a drug holiday, which you've been discussing, and that drug holiday is more to keep the cancer off balance than it is to get your testosterone to come back. A second option is to go on to monotherapy abiraterone, which we've seen a bunch of people do. So you just drop the LHRH and just stick with the abiraterone and the prednisone. But it's probably time to do something before that cancer becomes so comfortable that we don't know what to do with it down the road.
That's very interesting information, and something I bring up with Denmead when I see him next. He seems very receptive to new ideas. Obviously, he's sort of the leading guy on some new ideas.
Yes,
But
he
that's
is.
something I will definitely bring up with him. He seems to be slightly, although not dramatically, in favor of a vacation.
Yeah,
This.
the thing with Denmead Denmead has, we have a webinar with Denmead, I think from 2017 or 18, in the early days of BAT.
I've just watched it.
Sorry,
I said I just watched it.
you lost.
I said I watched it.
Oh, you just watched our, yeah, you just watched.
Yeah.
So Denmead's known us for a long time. We've known him for a long time. He's fine, but he's very buried in this testosterone alternative.
Right.
And that, that's the issue. At the same time, he's probably a very good person to be talking to about how do I get my testosterone back. And we've had some interesting discussions on getting your testosterone back, even in this group as recently as last week and the week before. I think the 14th of January, we had a really good discussion on should men with advanced cancer be considering supplementing their testosterone. that we're not talking about BAT. We're not talking about what Denmead does, just getting back normal levels. But that said, that's where I would be heading, Lee. I if it were me, I would be wanting to keep that cancer a little bit off guard and do something a bit different sooner rather than later.
All right, well, 2 points. One, Denmead has not even remotely suggested BAT with me, and I'm glad of that. If he had come out trying to sell that, I'd be a bit skeptical. The other question I have, if I do decide to either do a total vacation or go to a monotherapy, how frequently should I monitor PSA, and is there any value, and I doubt that there is, in a high sensitivity PSA test?
I think you should get monitored at least every 3 months. And if you're still at Hopkins, they're probably doing a pretty high sensitivity test automatically anyway.
Well, their test cuts down it considers undetectable less than 0.1, which is all I've ever had, either at Hopkins or at Maryland.
You know what? Rather than drive yourself crazy, stick with the 0.1, because we've got too many guys on this call who have a conniption when they go from 0.006 to 0.012, and we have to explain to them that we can't put a lot of weight in that. And if you're comfortable with the 0.1, you'll be just fine. I also want to tell you, you are unique, totally unique to me, and I think to at least one other person who isn't on here. You are the first person ever I've heard where Ted Schaefer recommended radiation. And I plan to, immediately after this call, I plan to call Jim Schrate, who is on the SPORE at Northwestern and who has extensive experience with Schaefer, and tell him that we actually found a guy who Schaefer sent for radiation.
Well, I will tell you, he was an attending at Hopkins at the time. He hadn't yet left to take over Northwestern. So I suspect he was very much under the influence of some slightly more senior people at Hopkins at the time.
He may well have been, but if John Maxwell is still with us, John, I am so delighted that you're with Scott Egner and not with Ted Schaefer.
Good. Thank you for that, and I appreciate the encouragement there. And I did take the Sloan Kettering nomogram while I've been on the call, but we won't talk about it now. All right?
Okay. Yeah, we don't have time. But you can hang on afterwards, and I'll stay on to go with it afterwards. But
thank you very much.
We have to.
Yes, or send me an email if you don't. Well, it's nice to meet. It's nice to meet you, Lee. And when you and Dr. Denmead figure out what to do, I would really love to hear the reasoning for why you decided one way or another with him.
All right, well, I will check back in with you guys. Thank you much for all of this information. It's been
and
very
Lee,
helpful.
do we have your email address so that you get our reminders?
Yes, I get your reminders.
Okay, great.
I'm going to mute my mic now, but listen for the rest of the session. Thank you very much, gentlemen.
Thank you.
I have one hand up, but it's Rick's. Are you still heavy?
No, that was for Lee Balin and to what I said.
Now, did you want to say something, Rick, before I start down the list? And please keep in mind that this list is something like 12 people long.
I know. Well, the first thing I'll say is we have no more we have no other meetings after this, which we usually do on a Tuesday. So I'm not going to ask Dr. John to stay because his good wife is probably making dinner, but I will stay as long as it takes to work with everybody tonight. The only thing I wanted to say at the beginning is we finish up our fundraising, our annual fundraiser this week. And again, we haven't had a great response, well under 10%, which is sort of disappointing. At the same time, a lot of people on this call have made donations and whatever you can afford, we appreciate. And we ask you to do it because you want us to be around. And I think we make a difference for you. So thank you, everybody who has donated. And if you haven't, we'll put the link in there. The other thing is that you can, if you haven't filled out our survey, and Dr. John, if whilst I'm talking, if you can put the survey link in the chat window, you have until tomorrow to do it, because Dr. John, who is in charge of the analysis,
That's it.
closing everybody out on Thursday. So if you have not, we have 400, or last time I looked, 458 responses across the board from all the AnCan groups. We would love to get your response if you haven't done it, but after Thursday, Dr. John is closing shop.
Steve, would you bring up what you had in mind? Steve L.
No, I haven't brought. Yeah. Do I have a few minutes now?
Yes.
Yeah. Oh, you might recall I'm metastatic castration resistant. Originally diagnosed de novo, so I've never had any previous surgery or radiation. I'm pursuing some radiation therapy now. Um, Originally had 2 bone metastasis and 2 lymph nodes, and the most recent PSMA showed no bone metastasis at those sites or anywhere else, and one of the lymph nodes had cleared. So, is there any reason to radiate former bone metastasis sites when they're showing clear of cancer? And has
If
anybody?
your cancer is expressing PSMA
Yes.
and it no longer lights up on a PSMA scan because you've had previous radiation to those metastases, then I would judge that it is not necessary to re-irradiate them. They're probably just little bundles of scar tissue right now if they're not showing up. On the other hand,
I haven't had radiation.
oh, you never had, oh, you didn't have any radiation. This is just a response to therapy.
Yes. The therapies I've had are just ADT, abiraterone, and then most recently the Provenge.
I don't think that a radiation oncologist would treat those metastases unless there's a suspicion that you have a non-PSMA expressing cancer. How do you find that out? Right.
Yeah.
You find that out by getting another type of PET scan, which does not light up PSMA, but will show up cancerous type of hypermetabolism, such as an FDG PET scan.
Okay.
You can also do it with an MRI, but I think the PET scan would be more accurate. I'd like to hear what Len and Rick have to say about that.
In addition to my most recent PSMA, I did have a CT at that time, and it produced the same results.
What did it show at the metastasis sites?
That they had cleared. No indication of bone cancer anymore there.
Len, do you think it's necessary to get an FDG scan to make sure that there's not some other type of metastasis in those bones, or a bone scan, in order to reassure him that he doesn't need treatment there?
I think so, mainly for the reason that, if I understood Steve correctly, he said he's castrate resistant. Is that right, Steve?
Yes.
So you can't be responding to hormonal therapy.
Well, I'm still getting some response. My PSA level is most recently was 0.79.
Oh, okay. Yeah. Well, yeah, if your doctor's willing to run the FDG scan, I would do that. The MRI isn't going to be able to distinguish between active and previously treated lesions. All I could do
as
is say,
well.
all I could do is do a comparison of the last MRI you had, and if they see that the lesion is bigger now, then that's an active lesion. Otherwise, they can't really tell. So I think the FDG would be the better choice. I don't know,
Yeah.
John, what do you think?
Yeah, that's what I was thinking.
Yeah, I mean, I
If
think
that's
an FDG
negative,
is a
I
good
wouldn't get
choice.
it treated.
Steve, when was that last PSMA?
Uh, January.
And last month, this
This
past month,
this month, yeah.
this month. And did anything show on the PSMA? Did anything light up on the PSMA?
Yes, one lymph node, and then there was some new uh, indication on the left seminal vesicle.
Okay, so we know we seem to think that you do show PSMA. Is that right?
Yes.
You express PSMA, right?
Yeah. Correct.
So these lesions that you're sort of concerned about, should we irradiate them? Where did we see those? What did that show up on?
That was on earlier scans, including a PSMA in this January, I think it was, of 2022.
Okay, so but why are you asking about that now? Have those shown up again recently on something?
No, but I was
Okay,
looking
so
at doing.
let me stop you. If they haven't shown up recently, we don't need to talk about it. If you express PSMA and if those lesions were active, they would show up on the PSMA scan. And I don't think you always this is a real tenet for everybody on the call. If you are going to do a test of any sort, you want to be sure that that you can respond to that test. You don't just do a test for no reason. And in this particular case, there's no point in doing the FDG PET, because if he expresses PSMA, and we're not talking about doing a radionuclide treatment, we don't need to look for anything else. We don't need to go looking for something when everything is fine. You're responding great. You've got a low PSA. We're treating what we see. If your PSA starts to rise, it probably is going to be associated with something going on around the SVI or the lymph nodes. I think the discussion we had with you last, from memory, I don't have it up here, was, isn't it time to do some debulking? Because you've never had any debulking, right?
Yes, and that's what we're pursuing now. And so debulking of the primary, and also hit that one at lymph node and seminal vesicle. Is that what I should be looking for?
Yeah. Yeah, the seminal
Probably.
vesicle we've been watching for some time. The lymph node presumably is in the pelvis.
Yeah.
If you don't have any pain in your femur or your back, do you?
Not now, no.
You have to consider symptoms also, I guess.
Yeah.
Yeah. So I think you're doing great, and we move along. But I don't see the sense. If it were me, I wouldn't be bothering with an FDG PET. I'd be happy with what I've got, and I'd be focused, as we talked about last week or the week before, on getting this debulking done. And that they need, and then, as I think I said to you, have a discussion with them whether they need to also talk about across the pelvic girdle, which would include the lymph nodes. That's really what was, why we were thinking. Do they need to do the lymph nodes? Sometimes they do, sometimes they don't. But that's the place to focus on the discussion for me.
Okay, and surprisingly, there was.
I really think Steve, we have to move on because we're so tight for time.
Okay.
I'm sorry.
Just write to me if you have another question. And thanks for putting that into perspective, Rich. I've got Tom Hoffman next, but I don't. Oh, there he is. Hi. What would you like to ask us about, Tom?
First of all, I do a lot of reading and talking to people, and I always hear the reference to your team, and get word back to your team, or what is meant by a team. I mean, I've seen a series of doctors, but I don't know that they ever talk to each other. And when somebody tells me, I talk to your team, I visualize a bunch of doctors sitting around a table talking about Tom Hoffman.
More and more in recent years, the doctors have relied on us to do the communicating. But so we have to take that responsibility, but they should be picking up the phone and talking to each other. I have a geomedical oncologist. I have an oncology APRN, a radiation oncologist. Some of us have a palliative medicine doctor. If we have heart problems and cancer, we have a cardiologist. And so that's your team. Now, it's loosely scattered all over the city, and it's partly up to you to make sure the communication is good. But that's what we mean by the phrase. If you're at a major center, they might all actually be in the same room, walking around the table, but more likely than not, they might be at different locations and maybe even different institutions. And we have to take our job seriously to keep them networked.
Okay. All right. My next question is, I hear the term, my cancer is in remission, or they've cured my cancer. From the reading that I've done, it seems like there is no cure for prostate cancer because it's never going to completely go away. And as far as remission goes, would I be correct in assuming that my abiraterone and Lupron, putting my PSA to less than detectable levels, means I'm in remission?
Yeah, you could use that word. Now, technically speaking, I think in remission, I'll ask Dr. Jeff for an input about this, but I don't use the word very easily unless the person is not actively on treatment. But basically, your cancer is asleep right now. You're not making any PSA. There's no indication of recurrence. You are on medications. So whether you want to call that in remission or in remission on therapy, that's what's meant.
Okay.
Jeff, do you think the word in remission applies if the person is on active therapy or no?
No.
No, and that's what I thought in remission meant also. So,
Okay. I'm still trying
Rick,
to
for
educate
example, is in
myself.
remission. He's getting no treatment, and his PSAs are non-detectable.
I would say you're not in remission, because if we stop the treatment, the disease would come back. Remission, to me, means that you are not on treatment and your cancer is not active. Now, we cannot cure. I will debate any doc who says we can cure prostate cancer if you've got a 4 in your number. And there are doctors who will tell metastatic patients we can cure you. It's wrong, in my view. What they should be saying is we can give you a continuing, durable remission, which is a phrase borrowed from Snuffy Myers. That was what he said. So we can keep you in durable remission for a long time, like me. I haven't had any treatment since 2011, and my PSA is still less than 0.1, but I'm not cured because I could go into the hospital for a test next week and find I have rising PSA. Ask Dr. Jack, he'll tell you, because that's what happened to him. But that's
Okay, well
different.
that validates my thinking that you really can't cure prostate cancer. It's always lurking there.
It
So
can
Only,
be, it can
only
be
if
cured.
you have a 3+3. If you have a 3+3, we can cure you.
okay, I'm 3+4.
3+4,
Okay,
yes.
next question is, um, I've done a lot of reading and research, and of course, there's all kinds of garbage out there on the internet and so forth. And I talked to my oncologist, and he says I have a 50% chance of living 5 years. There's the guy on YouTube, Dr. Scholes. He claims that he can treat people with prostate cancer, and they'll live 20, 30 years or die of something else first. I've seen other studies quoted that somebody in my condition is like 4 years maybe.
Let me answer that question quickly, Tom, so I can move on. In a way, both people are right. You can live 20 years, but you might not. And the variation in the prognosis of your cancer is very, very wide. So I think that it's fruitless to tell a person that they have a 50-50 chance of living 5 years, or even worse, to tell them you have 4 years to live, because the variation is tremendous. I think you should plan on many, many years and act accordingly. It might not happen, and it might happen, but and there's all kinds of, you wouldn't believe how many papers are coming out every day about new prostate cancer ideas. So I really wouldn't, I wouldn't be frightened by that 5 year statistic. I got something like 30% 5 years that you're going to live to. It should not be. The variation is too great to apply that to any individual, in my opinion.
Okay. All right.
The next on my list is Thomas, but he wrote to me and said he could wait. Is that still true, Thomas?
Yes, that's true, John. Thank you.
Okay, thank you very much. We'll get to you next week. The next one I have is, someone had their hand up. I think it was Jack. I'm sorry,
John. Just tell me, we have next week, who have we deferred? We've deferred Thomas, and who else did we defer? Somebody else.
I have to look at the chat to find out if anyone else wrote in.
Okay.
And we got to Gary N left. He might have been on my.
Okay, Gary N. That was it.
Yes, Gary N has left, and he was on my list to get to.
Okay. So because I'm moderating next week, I just want to give these people priority.
Thank you. Okay, I don't see anybody else. Jack, I'm sorry I didn't get to your question. I'm under a little time pressure.
Yeah,
Dan.
guys, I'd ask all of you, please don't send questions to the lead moderator during a group. It's very frustrating because we want to try and do things, but we just cannot do it. There's so much going on as a lead moderator that you're trying to keep track of. And I know it drives me nuts when people when I'm leading the moderation. If you're the second guy, it's easier. You can deal with it, but don't send questions to the lead moderator during the group. Please be considerate.
Hey, Dan, would you like to bring something up now?
You can pass. I can pass. I don't need to take any time tonight.
What's your last name, Dan?
Straub,
Straw.
S-T-R.
I got
Oh,
it.
yeah. Okay, put Dan on the next week list unless I
I
get.
have, but like I say, I'll stay on to take questions afterwards if it helps, because I don't want to back myself up too much for next
Yeah,
week.
we got next week's guys to worry about too, right?
Yeah.
I got Robert Anderson next. I can't find
Hello.
his. Oh, there
Yeah.
he is. Hi, Robert. What do you got?
Hi, can you hear me okay?
Yes, very well.
All right. So quick background, I've had my prostate removed. I had salvage radiation. Last year, I was on triplet therapy because it metastasized to my helium in my chest. So I was on Orgovyx and Erlida, and that was on the Medicare trial. They took me off of all hormone therapy after that, as per the trial. My PSA kept rising. Now they have me on Orgovyx and Xtandi, and I've been on that for 6 months, and just had my first seizure, and was wondering about anybody else that had had a seizure. They think it is probably related to the drugs. I have all sorts of tests coming up this week, but just wanted to kind of throw that out there to the group here and see if anybody has had that, or what would be next after they take me. And now I'm just on the single therapy, if they'll put me back on a doublet therapy, or what may be next.
Well, you're about to have a workup for that seizure. When somebody has the first seizure of their life, go in and try to figure out why. So you'll have blood tests, you'll have a
Yes,
CT
they've done that.
scan, you'll have an EEG, and if anything shows up to explain your seizure, then that will be treated from there. If everything comes up negative, you'll actually be like the majority of people with one single seizure and have an unknown reason. And it may be put on your triplet therapy simply because nothing else was found. Do you have any results of any of your workup yet?
Just the blood workup, and there was nothing that showed up with that. Just had an EKG yesterday, and we'll be having a brain MRI on Friday.
Okay.
How are you feeling after the seizure? Are you a little disoriented? How long were you out for, and what was the next?
I don't know how long. I would guess just less than a minute, you know. And I walked took a 2.5 mile hike the day that it happened, and so I'm feeling okay still.
So here's one thing that I would address with Dr. You're still with Dr. Van der Vela, right? Correct?
Correct.
Right. So here's what I would address with Dr. Van der Vela. He's sharp. He's knowledgeable. He's a good doc. He's a bit of a, personality wise, there are other issues, but he's a very, very nice guy. So there was, when Xtandi got approved, there was a 1% incidence of seizures. Mm-hmm. And so it was always said that this is a drug that causes seizures, but it was such a small indication. But enzalutamide, Xtandi, marched into the sunset with that mark on its back. It is a big enough mark for me to ask Dr. Van der Vela to put you back on treatment if they don't find anything else that would otherwise cause it, with darolutamide. because darolutamide does not go through the brain barrier. And it was also a big selling point for darolutamide when they took it to the FDA, that unlike enzalutamide, it didn't go through the brain barrier. So you are a poster boy for darolutamide to switch immediately to darolutamide from Xtandi. Plus, it's going to make you feel better, which is
Excellent.
which is a good thing. So
Yes.
I would has Dr. Van der Velde weighed in yet on this seizure that you just had?
I just saw the nurse practitioner on Monday, but she did go in and speak with him while I was there. They ordered the EKG and MRI immediately. I had the EKG yesterday, the MRI I'll have Friday. They also are putting me in with a Dr. Dixit, who is a neurological oncologist.
Okay. Okay, so in
yeah,
other words, you are pursuing this seizure through your prostate cancer team. You're not pursuing it
correct.
through another team. Okay, perfect. So as long as that's what they're doing, my discussion with Dr. Van der Velde would be, Dr. V, any do you think I'm a good candidate for darolutamide? And he might well say, well, if everything else checks out, yeah, that's where we're going. Dr. John?
Okay, great.
Yeah. Yep.
Excellent.
Yep. Blaming
Thank you, gentlemen.
the enzalutamide is what's called a diagnosis of exclusion. When everything else is ruled out, the only thing that's left is thought to be the case. Dr. Jeff, please.
Quick question: was this witnessed, or did somebody see you have this seizure?
No, it was I was alone.
So it may not have been a seizure. I mean, people.
The reason I believe it was a seizure was because I blacked out, and what woke me up was a noise that was like a ting ting ting, and as I was coming to, I was banging my head against a glass lampshade next to me, and my hands were shaking.
Did you lose your bowels or your urine?
No.
Yeah, you may not have had a seizure. I won't be surprised if your EEG, you said EKG, was it an EEG you had?
I am not sure. I thought it was an EKG, but it may be an
Well,
EEG.
did they put things on your chest or your head?
Yes, my chest and my ankles.
Okay, EKG. So you need an EEG.
Okay.
As well as I'm sure they're going to do a CAT scan, but you could have lost consciousness from some other reason and awakened. There are many people who lose consciousness and they use the word "I had a seizure," but the only way you know if you had a seizure if somebody is watching you and they can describe seizure activity. Otherwise, this may not be a seizure, and the terminology being used, is not accurate.
Well, yeah, I think they're just calling it like seizure-like, and they're looking into it.
That's good.
Okay. Well, thank you, gentlemen. I'll let you go on to the next. I appreciate.
Okay. Let us know what turned out to be the cause and do everything possible to find it.
Yeah, and Robert, I'd still use it as an excuse to get onto darolutamide.
yeah, good idea.
Definitely.
If it's easier on the body, I'm going for it, man.
Seriously, no, we're really serious about this because we feel that darolutamide is probably the best of the Ide brothers. It's different to abiraterone, so I don't want to say it's better than abiraterone, but if you're going to be on one of the Ides, you want to be on darolutamide. It's going to give you a better quality of life. It's just as effective. So I would lean on Dr. V to switch you to darolutamide anyway.
Very good. I appreciate that. Thank you.
Doug, I've got you next.
Me?
Doug.
Sorry, who did you say, John?
Doug D.
Oh, Doug D.
Oh, sorry, I didn't hear you. I am on blood pressure medication and a statin and metformin. And I understand that there are some differences in those medications. For the doctors among you, I have put a link, the first link in or the first note in the chat box is to an article about PPAR gamma. And if you get a chance to look at that between now and the next meeting, it'd be great. See if you think that it would be useful to have that in the drugs you use, because those are available in both the blood pressure medicines and the statins. And that's really all I have to say today. I just, I'm not so great at reading these, but if the doctors think that there's some merit in that, let's have a talk about it next time.
Okay, I'm somewhat familiar with all that, and anybody that wants to chime in?
Well, I maybe would like to open this discussion a little bit. We've talked a lot about statins, especially with Dr. Jeff over the last few weeks. And Doug, you sent this to me and you said, well, you thought simvastatin was better than rosuvastatin, and you were asking about metformin. And then there was the third drug, which I'm not familiar with, but I think John is. I'm not sure what that was for. Is that that's a blood pressure drug, I believe?
Blood pressure, ARB blood pressure machine, yeah. Blood pressure medicine.
And I encourage you to raise it. The first thing I'd suggest you do, Doug, is go to our search box and put in statins and put in metformin, because we've talked about this many, many times in this group, and there's a lot of good information within the group. As far as metformin, I'll come back to statins in a second, or I'll let Dr. Jeff talk about statins, because he's done some research recently that has caused him to switch his statins. But metformin is a very controversial drug. I don't take it because, thank God, I was only ever T3. But if I was T4, I would take metformin. I'd take a modified dose, because I think it does make a difference, and I think that controlling glucose is probably a good idea. But the evidential medicine says it's only effective if you have diabetes. And in the interest of fairness, because I said I would take it, I want to ask somebody who I know would not take it, my fratello Len, because he's done a bunch of research and he doesn't think metformin. Well, I don't want to say what he thinks, but I kind of know what he thinks about metformin, and so he ought to have a chance to talk about metformin, and then let's talk to Jeff, and then the third party of this will go back to Dr. John. Your views on metformin, Len?
Oh, only what you have already said, Rick, which is that the literature has never shown that metformin is of any use in patients, prostate cancer patients, who are non-diabetic. That's where my opinion comes from.
Mm-hmm.
My opinion is, for what it's worth, is like Len's. I think that if you have glucose intolerance as a result of your ADT, metformin is a perfectly good idea to keep you from crossing over into having diabetes. Otherwise, I think the final nail in the metformin debate came at ASCO last year, and I wouldn't take it either.
Actually, let me clarify. I'm on metformin. I'm not going to worry about whether that has any effect on cancer or not. It's the other two drugs that have this PPAR gamma that I think may be useful, and let
me say something about telmisartan then, and then I'll turn it over to Jeff. The ARBs are very similar in many ways, but telmisartan has a little bit of a additional effect, which is what Doug is talking about, and it does inhibit prostate cancer in cell culture. So you might wonder if someday people are going to say, if you're going to be on an ARB and you got prostate cancer, you might as well make it telmisartan. Doug is probably wondering whether it's time already to say that. I don't think it is. Well, all you got is cell culture, pre-animal research. I wouldn't switch just purely for that particular reason because the evidence isn't there yet. But that said, telmisartan is a perfectly good ARB. It's not that much more expensive than losartan, although it is somewhat more expensive. Jeff?
Well, there are articles that speak about the benefits of taking statins in men who are diagnosed with prostate cancer. It makes logical sense that if you take a statin, you're going to inhibit your cholesterol production, and that's probably a good thing because of testosterone precursor. And so I was on a statin, and then I had some side effects, and I stopped it. And then because of the discussions we had here, actually, I went back and revisited it and thought it was get over the side effect, deal with it, and get back on the statin, which I did. So I take my Lipitor every day now. And hope that not only does it control my lipids, which it does very nicely, but it also has an effect on inhibiting the prostate cancer too.
Jeff, do you have an opinion on simvastatin versus rosuvastatin, which is what came up in the article that Doug is referencing?
I have to read it. I mean, I take Lipitor, but I'd have to read comparative statins and which seems to have better activity. I guess it would all depend upon which controls cholesterol best.
For me personally, I happen to be on atorvastatin, and I'm happy to be on a statin anyway because I have prostate cancer, but I wouldn't go on it purely because of prostate cancer. Whether one statin is better than another, I can't answer that either. I think the evidence might be there for simvastatin and not for some of the others, but that doesn't mean they're not all the same.
I didn't go on it for the cancer. I was on it for elevated cholesterol and triglycerides.
Nobody goes on it just for the cancer. I wish that we had a lot of time because Doug has raised, these are really interesting questions, I think. And I can follow up with Doug. It deserves more attention and discussion.
Doug,
thank you very much.
Doug, which was the preferred statin in that article that you read? Can you tell us why?
Simvastatin, and it's because it has this PPAR gamma and I think something else that was supposedly able to inhibit the growth of cancer cells.
Okay.
And again, I think I don't know of any human studies. I think again that's something out of a petri dish, and maybe mouse studies. So I'm not sure, but my question is, so since I'm going to be on the blood pressure medicine and since I'm going to be on the statin, why wouldn't I select these specific ones for the possible added boost? I don't see a downside.
I don't see a downside either, although I don't really see that it's indicated yet to do that.
Okay.
But there's nothing bad about simvastatin. There's nothing bad about telmisartan. So it's not like you should avoid them for any reason.
Thank you. I'm certainly ready to move on.
It's a great question. Very interesting. Next, I've got David, VDM, are you still here? Yeah, he's still here. David, can you unmute and tell us your question?
Yes, thank you. Just a quick report. I started on Lupron in November, with Exgeva injections also, and I'm taking abiraterone and prednisone daily. My PSA was 132 in November. By mid-November, it was 8. By the 1st of December, it was 5. Mid-December, it was 0.53, and mid-January, it was 0.1. Rick and Jim Marshall both recommended I stop seeing my medical oncologist and go to see a GU oncologist, Dr. Poller. Just want to let you both know that I saw her today. She's happy with the response. Rick said to ask about radiation treatment, radiating the primary, and both she and the radiation oncologist said it's not a good idea to just keep doing what I'm doing. Today she told me if I go 2 years, she says basically 0.1 is undetectable in her opinion. She says if I stay 0.1 for 2 years, she'll put me on vacation, but she said she'll readdress it after 1 year, considering the benefits you all talk about, the vacation. I'm seeing her once every 3 months now instead of once every month. That was just a quick report to let you know I took your advice, and thank you for the advice, and it seems to be going well. Thank you.
Well, that's great. Do you like Dr. Power?
Everyone likes Dr. Power.
Yeah.
She's very knowledgeable, obviously super intelligent, and she has a great sense of humor.
So, Rick, do you want to pick up on that radiation part or anything?
Not at this point, but what I did want to say is, David, I know we've corresponded, but I don't think we've ever done an intake on you.
You did, Rick. I joined in November, and you did the intake, and that's when you and Jim Marshall privately kept saying, "You need to get to a GU oncologist."
Yeah, well, I remember that, but I can't
just
find
want
you.
You to know that I did it.
Yeah, I can't find you in my. I don't know why I can't find you in my contacts. I don't know what happened. You got lost.
You did
He's
it.
not in my file either, Rick.
Excuse me, Rick. Is he under ELS or Vander?
I've looked and I don't find it either. That's why I. Oh yes, now I see it. I've got it. I
under
got
ELS.
No, but I got it as a van and then a DER and then an ELS. So that's good. I mean, I definitely remember you, David, and I remember sending you to Dr. Pala, and I'm really pleased that you liked her. We thought you would. She gets great reviews. I don't know really what to say about debulking the primary. I mean, we see it frequently. Why they would want to do it for you, that I cannot say. There may be other
considerations. You say
considerations.
why they do not want to do it for me?
Yes, why they don't want to do it for you, I don't know. But
I asked her that. She said she did it once before recently to someone who, like me, was responding nicely, and she said it increased the PSA. And so,
well, it will. Yeah, I mean, and that happens, but then it goes back down again, and it can do because of there's inflammation and different stuff that's going down. But the question I would have had for Dr. Pala is, at what point did it increase it, and what happened 12 months later?
I didn't know enough to ask those questions.
Yeah, but look, we'll revisit it. There's no real hurry. We'll revisit it, and just because she said no now doesn't mean she wouldn't say yes later if we thought, but if we got you under control and we got you with a good doc, then you're okay.
One more question, Rick. What are the advantages of you calling it debulking? What are the advantages of that?
Well, what we've seen, and I'm pretty sure the guys, Len and I don't know, Len may have dropped off by now.
Len is gone.
Yeah, John may know, but there have been, I believe, some studies pointing to the fact that there is a benefit to radiating the primary in metastatic men. There's definitely been studies around surgery that I know, and I'm pretty sure, and I'd have to go look. I can't do it right now, but there have been studies. I want to say they came out probably around 2020, I think 2019, 2020, sometime around then, recommending debulking the primary.
Might
Well,
be a
when
good thing for an introduction sometime, Rick.
Yeah, it would definitely be. And if I find anything, David, I'll send it to you. But I'm pretty certain there is empirical support for debulking the primary now.
If you find something, please send it, because my first doctor, Dr. Sampath, the medical oncologist, was against it, and Dr. Poller was immediately against it, and then I don't know which radiation oncologist she conferred with, but he said, "Oh no, don't do that." So just reporting back.
Let me ask: do we have anybody in the group here who was de novo metastatic and then they came in and debulked the primary? Because we've had a bunch of guys where they have done it. So Larry Fish, speak up, please. Unmute.
Not immediately. It was later.
Right.
Like 8 years ago, they said, first person, cat's out of the bag, there's no real point. That was 8-9 years ago. Eventually switched to, Dr. Audio at Sloan, and was on Lupron, darolutamide. And a couple of spots came up on a PSMA, T6, and something around the prostate, and went to see, what was his name, the radiation oncologist, one of the good ones at Sloan, and they worked together as part of a team, I would say, and they communicated pretty well, and went in for T6 and to debulk the prostate, and that was.
That doesn't sound like, strictly speaking, it's debulking, because they went in because you had new growth. They didn't go into
not in the prostate, John.
Oh, it wasn't. Oh, okay.
No, they found a spot and a T6, and they did T6 and they did the prostate and knocked it out.
I understand.
Now we're following it. It's undetectable 2 years, and I'm enjoying life with that.
Alan Edel, some of you know Alan as Tall Alan. Those of you who are on Health Locked Out know him as Tall Alan. Alan Edel has done an article on debulking the primary, which will have every possible bloody reference there ever was in it. And here I'm posting it right now. So David van der Els, please click on that link that starts Alan Edel. Take a look at that. That's probably going to give, if there's any evidence out there, it's going to be in that. Now, I see when I click on it and I see the title, it's in men with low metastatic burden. How much cancer do you have, David?
I think the MSA showed either 5 or 6 regions.
Well, 5 or 6 is relatively, it's arguable. But one could argue 5 or 6 is pretty good because some people light up like a Christmas tree and others would say no. But I think that if you are
Well, where were the 5 or 6? Were they close to each other, or were they spread out?
No, they spread. I just recall that that's what Dr. Powler said. She said it's already spread. I have one in my collarbone, 5 tiny ones in the center of my thorax, one lymph node in my pelvis, 2 in the pelvis bone in different areas. So there's 5 in different places. Rick, I just recall that's what I forgot she said that. She said it's already spread.
so that might be a good reason. I mean, it's always spread if we are treating somebody who is metastatic, it's spread. So and you know that's always, and the reason has been, well, you don't treat somebody where it's already spread, but we know that it's right to treat metastatic men and debulk the primary, but maybe only certain circumstances where the metastasis is limited. Read the piece that I put in there, and that might throw some light on it. And
I'll do that. Thank you.
Maybe I'll write a future invite about it because this comes up fairly often. You know, Rick, we've put off 3 guys for you for next week, and I have Artie still on the list today, but I don't see him anymore.
Artie's there. I see him.
Artie, what did you have to bring in today?
Oh, and we had Jim Thompson, who's going to the doc tomorrow. But Jim may have left.
I don't see him. I don't see Artie either.
Yeah, I see Artie.
There he is. I see Artie. Artie, what would you like to bring up today?
First question, I need some clarification. I'm confused. When I have metastatic in my collarbone, does that mean I have a lesion or tumor cells? What does that mean I have there?
It means all of those things. You have, if it's prostate cancer in your collarbone, then it means you have a bony metastasis of prostate cancer. It's a lesion because a lesion just means anything that's wrong. It could be an infection, it could be a cancer, it could be an injury, it could be anything that's wrong. And it's cells because that metastasis is made up of cancer cells integrating themselves with the bone. So all 3 are true.
It could grow, if it's a lesion or tumor, it could grow bigger if not treated.
It's possible that it could grow bigger if not treated, yes.
The reason I asked that because when I talked to my radiology oncologist, they suggested that I have 5 treatments of radiation and then go on to therapies. But he told me that it was optional, and I asked him why, and he said because if you're going on the hormone treatments or the other treatments, that is basically going to do the same thing as the radiation is going to lower testosterone and make this, I guess, make it smaller anyway with just the hormone treatment. So I asked him, well, why would I do the radiation treatment if that's the case? And he said, well, it's your option. That's what I'm confused about.
If the radiation treatment, in other words, you could go on hormone therapy and kind of put the thing to sleep so it becomes inactive, but it won't kill it. And then if it ever becomes more active again or your PSA rises, you could have radiation then. The radiation could potentially completely kill the cancer cells in there, which the hormone therapy cannot do.
Oh, okay. He explained it to me. Okay, so it can kill so if I have the shot in the clavicle with the radiation, that could kill the cells in the clavicle, but the other parts of my body, the hormone treatment will not kill it, but it'll keep it at bay, basically, is what you're saying.
That's right.
Okay. Also, my doctor, Dr. Pranik suggested, because I asked her about the Orgavix, I think it's called, and she said that she'd put in the order, but she's seen with the VA because it's more expensive than, I guess, the Lupron shot, that they might deny it because she's tried it before. So she said, I'm waiting to see if they deny it or not. But she said if they don't deny it, she'll give it to me. But if they deny it, she suggested instead of going on a Lupron shot every 3 months, I should go on something called it's with an F, Formavix or something like that. It's called
Ermagon.
Firmagon. What's Firmagon?
Firmagon.
Yeah, that's once a month and not every 3 months. What's the advantage of Firmagon versus Lupron?
Well, it must be cheap. Firmagon is not as expensive probably as Orgovix. And it's a perfectly good ADT. It'll lower testosterone levels right away, and it'll help them pop back again someday in the future if you do have a drug holiday. The problem with Firmagon is that quite a number of people have very, very sore bellies when they get shots of Firmagon. Sometimes it can really hurt and react, and you have to get off the drug. It's a very good starting drug because it doesn't cause any kind of a flare in your testosterone like the other ones can.
Yeah, I think we're going down a rabbit hole here, Dr. John. Orgovix and Jim Marshall may know more about this, but we have not seen a problem getting Orgovix from the VA.
Wrong.
Not true?
I just tried, and they said they don't stock it. Well, here. They said it is not within their formulary within the Washington, D.C. hospitals. So maybe some of them have it and some of them don't.
Okay. Yes, Larry Schuler. Larry Schuler, use the hands up function.
In Alaska, Orgovix is the go-to ADT.
The VA?
At the VA.
Well, see,
so it depends on which region you are.
Yep. It probably depends upon a region.
Yeah, I'm Northern California.
So I don't know, but I think in California we've had VA guys use it, and again, this is something to take up with Bing Crosby, Jim, because I thought that he had negotiated that Orgovix was available across the board at the VA. So what I would say to Artie is, you may well be able to get it. If you don't get it, then come back and talk to us. But let's not talk about the ifs, ands, or buts until we know you don't get it. And as I recall, they put you on bicalutamide anyway, didn't they?
She didn't. She told me not to take it because we're going to have another discussion in about another 2 weeks, because I asked her about the I remember I talked to Jim Marshall and he explained to me about I was worried about the weights and the muscle and all that, and so I decided to take 3 weeks off and work out really hard and get my muscle mass up, so when I do go into treatment, I can maintain instead of me trying to build while I have no testosterone.
Okay, but that's not, again, let's just stick on the topic here, which is bicalutamide.
Right.
You don't need the bicalutamide if the first shot is Firmagon, so you can just use that for the first shot, and then you could switch to something different, or if you go on Orgovix. So hold off on that bicalutamide, like she said, and let's see if you get the Orgovix, and then they'll put you on the Orgovix. General, did you get Orgovix from the VA in DC?
No, could not. I concur with what Jim Marshall just said. Could not get the Orgovix from G, even though I've heard in my prostate cancer support group and also in this group that guys in the Midwest had no problem getting Orgovix. So it's not. It goes by region, I guess. I don't know but obviously it's a lot more expensive than Lupron.
Yeah.
I don't know why the VA is not consistent on this.
Okay, thank you. Thank you for that. So let's see where they come out. If they say no, then get that first shot, let it be Firmagon, which is what Dr. Parrick is correctly saying. And then after that, you can go to a 90-day Lupron shot, or whatever LHRH drug, whatever LHRH agonist that they use.
So
For your purpose, right now, Artie, follow. Let us see if she can get you the Orgovix.
So just one more question. So the Pharmagon is only, it's not, it's only one shot. It's not like it's not like the Lupron where you take every 3 months.
No, it's like the
Once a month.
Lupron. It's just the same as the Lupron, except it's more expensive, so they don't always want to give it. But you really only need it the first time. Okay? You can keep going with the Pharmagon. Some guys do. Some guys do not like it because it's a shot in the belly, and it's a harder shot for some people to manage. If you want to keep going with the Pharmagon, you can keep going with the Pharmagon, or you can switch to another type of shot.
Okay.
Okay, David Van Dels, don't leave because I have a question for you. I just was reading your notes. All right, Artie, are you clear on that?
I'm good now. I'm good. I'll wait. I'll talk to the doctor. Clear.
Okay, everybody, thank you so much for coming. I'm sorry to hold you
Hold on,
over.
John. Hold on. David, did you talk to Dr. Palla about doing a somatic test on your tumor?
No, I don't know what a somatic test is.
Okay, well, I know we did talk. I said we also spoke to you about somatic testing, and we want to know what sort of mutations your cancer expresses.
Right, I'm writing this down. It's called a somatic test.
Next generation sequencing, somatic next generation sequencing. That is actually.
How do you spell it? I'm sorry.
Next. Somatic is spelled SOMATIC. And it's next generation sequencing. Okay.
Is this a genetic testing?
It's the type of genetic testing. It's not for the inherited gene. It's for the mutations you make yourself.
All right.
And the guidelines require that you be tested for that with your level of prostate cancer. So what you want to be talking to Dr. Palavan, you can send her a note and say, Dr. Pala, I have not had somatic testing. I would like to be tested. And if she gives you any grief on that, it is in the NCCN guidelines for somebody of your level. Plus, we should, depending on what that somatic test tells us, we may need then to do a germline test, but we can do the somatic test first. Germline is for inherited.
And I'm sorry for dragging this out. And this will show if I have mutations?
It'll show if you have mutations and if you're a candidate for any particular drugs.
Okay.
And it should have been done when you were diagnosed metastatic. Now, if she says, well, we don't need to do it now, you say, well, we can do it now and we can do it again later because they pay for it more than once.
Okay, I'll ask. Thank you for the tip, and I'll ask her about it. Okay, I think it was the hereditary genetic testing that was done by Dr. Sampat when I first was diagnosed. I don't recall this name. Somatic.
Right. The somatic is looking at the tumor itself to see if you have made any mutations, if your body has made any mutations. The inherited is looking at what you inherited.
Okay. I'll look into it, and thank you for pointing that out.
Okay, and Jim Marshall's nodding his head, so you can always reach out to Jim.
Absolutely.
and you
Okay,
know
Jim,
what,
thanks.
we are not big fans of Gardant, so we would say probably Tempus is the best place, but I think she'll get it from Tempus or Foundation Medicine or somewhere like that. But we should really be testing you. We probably cannot do it with your from your blood right now. We may be able to, but probably cannot, unless you've got a significant amount of circulating tumor. So we would have to do it from a metastatic lesion if you have one. Didn't you say
Okay.
you? Sorry.
Yeah, there's a lymph node in my collarbone. They said the lymph node in my pelvis, the lymph tumor in my pelvis is too close to the blood vessel to take a biopsy.
So the lymph node in the collarbone would be perfect because it's probably easily accessible.
Okay, I'm going to ask her. Thank you.
Okay. I am now taking over from Dr. John. Because as I thought, Ray's after him to have dinner. I'm happy to. Dan, you said there was something you wanted to discuss. If anybody who's still on this call has something that they want to discuss, just please put your hand up, and then I'll go around you that way.
Yeah.
The hands up function for anybody who doesn't know is at the bottom where it says react. Dan, what's on your mind?
My PSA is remaining low. Can you hear me, Rick?
Yes. Yeah.
Okay. It's still at 0.01, which is great, but the side effects, especially into the hip joint now and the SI joint, is serious, I think. There was an x-ray that they did last week. It just put me on different exercises, but in the back of my mind, I'm thinking that there's some side effects from the HT and also from the radiation. I can't get a verification of that. But when I brought all this up, along with other side effects, to Dr. F, she allowed me to reduce the dosage of the Abby to 3 pills a day instead of 4, which is good. And I'm just going to wait until next week with the new blood test. But I've always been on finasteride. That's my next question. Should I drop that?
Well, first of all, we can't give you medical advice, so I can't be telling you whether to drop or not. I think that's a discussion you should be having with your lady. What's the name again? What's her last name?
Ferreira?
Oh,
Fereira.
she is a Kaiser
Right,
doc.
I know that. And what's her name again? Pereira, is it?
Dr. Ferreira, Ferreira,
Pereira, right.
Eva.
Right. So I think that you've got to, Dan, you've got to have a discussion with Ferreira about whether you should or should not. She should have addressed it, whether you should still be on the 5-alpha reductase or not. As far as your joint pain is concerned, I know we did discuss that last week. I don't know what to say. I mean, there are a couple of things that occur to me. One thing is we probably should be verifying that there's no site of metastasis there. When was the last time you had a PSMA scan?
Probably 6 months ago, and that's the next on the list after this blood test. We talked about it in December, but we put it off until this year. And when I do the next blood test next week, I'm going to discuss it with her to get that next PSMA.
So I have a note that the Euro agreed to a PSMA test in June. Did you do it at that time or not?
Oh yes, that was done.
Okay. And we didn't see, and it was negative. We didn't see anything, correct?
When they did see it, that's why they did the radiation. They were concerned with the liver, and that came back negative with an additional scan.
Okay, so I'm just looking at there was some lymph node involvement, but there was no bone involvement though,
That's
right?
correct. There was no bone involvement that they found at that
Right.
time.
So what I would say to you then is talk to Dr. If it were me, I'd be talking to Dr. Ferreira and saying, look, can we completely verify that I don't have any bone mets there? We need to be looking because it could be bone mets, but it could also be, as she's correctly thinking, it could be a side effect of the ADT and the ARSI, because guys have that, and it does happen. But we need to make sure you don't have any bone mets, and the only way we can do that is through a scan, and we could do an FDG scan, or better still, we could do a PSMA scan.
Or both.
Um, I look, it's going to be tough for you to get both at Kaiser.
Right.
Number one. All right. So you met the enemy already. And if they're going to give you a PSMA scan and you start bringing up an FDG scan, they're going to say to you, oh, well, we'll do the FDG instead of the PSMA. And then you're going to say, well, no, I really want the PSMA. And then you're going to get yourself in a bind because that's Kaiser.
Right. But
all right.
Both Jim and I have had this situation in discussion. They usually require you to do the bone scan or a CT scan before the PSMA. And I think that's what's going to happen. I'm going to ask her based on your discussion right here for the bone scan, and then follow that up with the PSMA scan.
No, I would ask. I'd go straight to the PSMA scan.
Great.
Don't even, if she says, well, you got to do a technetium 99 before you do the PSMA, you say, okay, I'll do it. But the technetium 99 is unlikely to show you a result because it's an old technology. It's not effective.
Perfect. Thank you. Thank you, Rick. I don't want to take any.
Okay, so what I would say with this, does anybody else have any comments for Dan on this issues around pain and hip pain and what have you? Okay, so I think that's the best way to go. Keep talking to the captain. He knows what he's talking about sometimes, and you can reach out to me as well if you don't get anywhere. But I think I think that's the way reducing the Abbey. That's certainly a good idea. The best thing for you to do is to get yourself out of Kaiser and go and go along with David Van der Els to see Dr. Palla. That's the best thing you can do.
All right. Thank you, Rick.
Okay. John, back to you again, John Maxwell.
Very good. Thank you very much. I just want to say this is a breathtaking group. The expertise here is stunning. And it's great that I'm here. I wished I'd been here a month ago. Okay.
Well, it's not too late.
Yeah. So I was officially got my diagnosis the 27th of December. And so I did the Sloan Kettering nomogram using 25 as my PSA, doubling the asteroid. It said 15-year prostate-specific survival rate, 76%. Progression-free probability after radical prostatectomy, 5 years, 30%. 10 years, 18%. So 70% chance I'm going to have radiation treatment.
Well, that's where I was. I was a similar diagnosis to you, but I had a little more cancer, but not a huge amount. And for me personally, I didn't want to roll the dice on 30% and have to go through all of those extra comorbidities, particularly with the with the urinary issues and everything else. I said, screw it. If if I'm going to have to do this anyway, I'm going to forego the surgery. And as I said to you earlier on, I did check with Peter Carroll, who, you know, might some people might say he is the father today of all urological oncologists throughout the whole country. And you know, he said, well, probably a difference of 3 or 4%. And I've actually heard somebody else say less, but it's very hard to get. I'd be interesting to see what Egner says. Ask Egner, how much better off am I going to be if I've got to do surgery and radiation and hormone therapy? And you're probably looking at between 18 months and 36 months of hormone therapy, most likely around 2 years.
Yes. So Egner gave me a prognostication, right? And I'm always a tiny bit skeptical, right, when I'm talking to the radiation and talking to the surgeon. But he said we've got a 60 to 70% chance, and I'm going to go with the 60, that we can get you to cure. And that seems unrealistic, right?
Well, the first thing I'd say to Dr. Egner is, since when have you been able to cure a 4+4?
Right.
Now,
Okay. Fine.
And did you mean a continuing durable remission?
That's
or did
probably
you
what he
mean
meant.
cure? Right. So I wish they'd be, and I've heard Egner use cure before, and I wish they wouldn't use it, because cure means it's never going to come back. And you need to ask Dr. Egner, Dr. E, are you telling me that it will never come back? And then he's probably going to say to you, well, 60% that you know, will get you fixed up for a good period of time, but it might come back. Well, that's not cure.
Okay. He also
Okay.
said at this point, and I'm very early, right? 20 to 30% chance that we've got microscopic metastasis, which somehow, as I learned, is not
Okay. Well,
having.
The Memorial Sloan Kettering nomogram, print out that Memorial Sloan Kettering nomogram and give it to him and say, how come this is so different from what you're saying, Dr. Egner? Because what the Memorial Sloan Kettering nomogram is saying is there's a 70% chance that this is already out the capsule and you're going to have recurrence. Now, what you'll be faced with, because he's super smart and he also has an ego and he doesn't like to be wrong, is he's going to say, well, these nomograms aren't true anymore because things have changed and we can do better than we did do, and this and that and the other. But, you know, if it were, I would say that given what you've told us and a PSA of effectively 25, right, and only the metastasis, only the lesions that they've seen in the prostate, which seem limited. That's why I asked you if they did a transperineal, which they did, and that's all they saw. But I'm concerned that there's something else going on there. And to me, 60% likelihood that you're not going to have recurrence with your disease. It doesn't sound right to me. It doesn't sound right.
Here's where I'm sitting right now, and I'm listening to all these amazing men and where they are and what they're going through. I'm on the first square of the board, right? And I was convinced I was doing surgery yesterday, but now I'm questioning that because the oncologist I'm talking to, Andrew Lee, who seems to be pretty darn good, right? His suggestion was, hold on, let me get to it.
I don't know who Lee is. Is this the radiation oncologist?
Yeah, in Barrington. He's at Good Shepherd.
No,
but he said,
no. I don't want to even listen to Mr. Lee, Dr. Lee. go talk to a radiation oncologist at U of C.
Okay.
Okay? I mean, there is a reason why these guys are centers of excellence.
Okay.
And what you need to do, you don't need to do anything. Forgive me for putting it that way. What I would do
might consider
next
it.
is ask Dr. Egner, tell him that you would like a consult with an RO, with a radiation oncologist. Okay. I don't know the radiation oncologist that well. We know the GU medical oncologists and we know the surgeons, but I would have to look to see before you ask him who he suggests, but don't accept the appointment and then come back to us and we'll tell you. There are a couple that I know, names that I know, but I got to refresh my memory.
Hold on a second here. I might have it.
Has he suggested somebody already?
Yeah, hold on. Hold on. No, I'm not finding it right now, but I had an appointment with somebody and I decided, no, I'm doing surgery, so I canceled it, but I can get it back on, right?
I would, I mean, first of all, even if you've decided, you still should be listening to what the radiation oncologist has to say. That's sort of the way I think, as part of your education, I think it's sort of important to do that. I see your hand up, Robert. I'll come to you in a minute. I think you owe yourself in any circumstance a consult with a rad-onc for your situation.
As a primary therapy.
As a primary therapy, yes, as an alternative to surgery. Now, Egner's not the type of guy that is quick to cut because he's very good for active surveillance. If we want a guy to be convinced that he should stay on active surveillance, we might send him to Egner. So, I respect him in that regard. At the same time, I think in your case, to tell you that he can cure you and there's a 60%, he's got a 60% cure is hyperbole. And I'd say that to his face. He wouldn't like it, but I'd say it to his face.
The guy that I have the appointment with, Dr. Muzamal Arshad.
Arshad. I need to pull up the University of Chicago. University of Chicago. I need to pull up the list of radiation oncologists and see if I recognize any of their names. I think I have heard his name before, and I think we've had other guys who have seen him. Who did David see? David Muslin has definitely seen a rad-onc at Chicago, but he's not on the call today. Let's cut that. Let me go here. Robert, talk to us whilst I'm looking for this.
Okay, Dr. Lee did my salvage radiation in Barrington, and my PSA actually doubled during that radiation, and then I switched to Northwestern, and my radiation oncologist there was Dr. Sachdev.
Right.
Yeah. So I know you're in a different system, but still somebody else in the Chicago area that I was sitting in the waiting room last time, and I think there was 5 of us that had the same radiation oncologist, Dr. Sachdev, and my oncologist at the time, Dr. Ross, said when they found the metastasis that he would, if it was his brother or uncle, that he would definitely recommend Sachdev.
Sachdev, okay.
Yeah,
And
but
that was with Northwestern.
yeah, but he's at Northwestern, and I would say to you, you don't want to mix them up.
I'm looking at the radiation oncology team, right?
Yeah.
On the University of Chicago.
Yeah, so am I. Again, I can have. I need to ask David Muslin, and I can drop David a line and ask him who he's seen, and if not, to ask Dr. Shmulewitz what his preference would be.
Isn't Dr. Lee with Advocate?
Yeah. Is that the one you used?
Yeah, yeah. So how was that connected to University of Chicago?
It's not, but Dr. Lee is 6 miles from my house.
Ah.
And he's head of radiation oncology for Advocate Good Shepherd.
Great.
Okay.
But
you're using two different systems? Confused a little bit. You're already with University of Chicago or University of Illinois? Or just
I went down to Chicago because I was referred to Egner. So
you're better off with Egner. I know. I mean, I lived in Chicago a long time ago. I know there's distance involved, but
I don't care about the distance. I don't care about the distance.
John, you're doing the right thing. You're seeing Egner. You'll find a radiation oncologist. Did you say the guy's name? Was it Awan that you said? AWAN?
Arshad. Muzamil Arshad.
Yeah,
Muzamil Arshad.
Okay, well, I don't even see him listed, which makes me think that he's probably new, and he has space on his
No, I'm looking at his badge on the radiation oncology team.
Really? I don't see him. I'm looking at that team too.
I can't share my screen, can I?
Oh, I see him right at the top. Yes, there's no picture. He has no picture. Now I see him. Yeah, sorry about that.
That's okay. So of all those people,
where was he? Where did he do his training? Yeah, he wouldn't be my choice. I don't think he would be my choice. He did his residency at U of C. He went to Wayne State, which is not bad. Probably wouldn't be my choice. I think Awan is pretty good. I'd really be wanting to see somebody more experienced.
Okay.
To be honest, I think, and let me find out from. I think Shimura. That name is really familiar.
If you could give me a recommendation on a name, because I got a lot of balls moving right now, but I still haven't been cut. Right, I still have not been cut.
That's right.
And so I think I still have a little bit of space to move. But if you can recommend a name on that list, that would be great.
Okay, for want of a better name, and I'm pretty sure this is the guy. Initially, I would say Shimura, Chmura.
He looks like a young guy, but he's probably not, right?
He's not so young, and he is a professor.
Okay, and he went to U Chicago.
But he might be their brain guy. But I'm not sure.
Okay.
Okay, but and this Haraf, where's he? He went to Rosalind Franklin. Bloody hell. Rosalind Franklin keeps coming up in my life on a daily basis right now. In fact, I even have to give her a call later tonight. It's ridiculous how she keeps coming up. Um,
Am I looking for somebody who specifically says prostate in their bio?
genitourinary. Genitourinary is what you're looking for.
Yes, urinary, got it.
So you're looking for a GU, and let me just do one other quick thing. Let me just see if I've got a name in David's. See who David saw. David Muslin. I have a feeling. All right, no, I don't have a name, but what I'll do is I'll send David a note after this and ask him to get a name from Shmulewitz as to who he likes
Okay.
best for
I have created a like a 3-page summary of my whole history, including the notes from both Dr. Egner and Dr. Lee. Is that something I would go over with Dr. John, or that's not a thing?
Well, if he's got the time, I just don't have the time. I got it.
No, I
I'm
realize.
sorry, I just don't. But if John's willing to give it to you, but again, it's probably not necessary in the sense that we know what's going on with you. We're in. Is it going to change where you are right now? Probably not, unless you've got some. Do you have any other medical comorbidities that would make radiation a not a good choice?
I don't think I do, and I have no comorbidities. The crazy part is, and this is, don't get mad at me, but I feel pretty damn healthy.
Yeah, right? No. I mean, we don't get mad at you. I mean, it's great, and that usually is what happens with prostate cancer because it's asymptomatic. And thank God you found it before it got to be symptomatic. That's that's the good news. So I would say if I wouldn't take his time to go through it because he's wonderful. And I was talking to somebody earlier on about this today. We are not really set up for personal navigation.
Got it. Fine. I'm good. I got a ton here. This was really great.
Yeah, I mean, we do personal navigation. I ask always for somebody to make a donation if I do personal navigation, only because I want people to respect time, and I don't want them them going after me or any of our moderators just as a security blanket, because that's what the group.
We all need security blankets. I got it. So Muzamil is an assistant professor of radiation and cellular oncology. So, but they probably all are, right? So.
Well, no, some of them are associate professors, and some of them are professors, and the assistant professors are the youngest ones and the lowest ones on the totem pole.
Got it. Okay, very good. So if you can send me a name at UChicago, but here's what I'm going to do. I'm going to start rolling on this hard. I'm going to start rolling hard on this, and I'm going to get in front of the radiologist. And I will tell you that this conversation tipped me in the direction of looking at radiation as a primary treatment, because it looks like I'll be there anyway.
That's the point.
And by the way, if I get radiation and it comes back, what are my options? Radiation again?
Yeah, they used to say to you can't do it, but it's not true anymore. There's loads and loads of options. And any doctor who tells you, don't get radiation because we can't go back, that's no longer true.
Because they can do the very targeted radiation lesions and so on.
There's all kinds of treatments that we can do. It used to be a good argument 20 years ago. It's not a good argument today.
Okay.
And I think if you bring this up with Egner on this basis, and I think you've got to get Egner to be more realistic with you, because I'm not that convinced. And the other thing is, I really would urge you to get that second opinion on your slides, because if you're not a 4+4, if you're a 4+3, then all of the numbers on that surgery turn around.
Yes. And if we're a 4+5, it's probably not all that different.
Well, if you're a 4+5, you're much more likely to have recurrence.
Yeah, excuse me. It doesn't change the course, right? It doesn't change.
Well, it may do, because if you're a 4+5, it's going to convince you more that not to do the surgery. And if you're a 4+3, it's going to convince you more to do the surgery.
Got it. Because the chance of spread.
And you haven't had those slides read by a really good eye. And that's why we're saying get them reread.
Can you send me the name of somebody who is a really good guy to read them?
Let me put it in. Let me do it right now, because otherwise I'll
put it in the chat.
So you've got two people. You've got Epstein, who I would go to, who's about to get back in business, and you can write to this email for Dr. Epstein to get more information. And you'll have to ask, when's he back in? There's a new, this is, I guess, his assistant. This is where he's,
Dr. Epstein, is that at Johns Hopkins?
Well, he was, but he isn't there. He hasn't been there for 2 years.
Okay.
Hold on a minute. Everyone. There you go. So that's the information for Epstein, and he's got a new he's got a little announcement thing which he sent out. And
what institution is he with now?
He's working with Integrated Medical Professionals. He's working as a consultant. Integrated Medical Professionals out of New York.
Not in New York? Okay.
Yeah. And it's Epstein. Sometimes I pronounce it wrong. And he's on our advisory board. He knows us very well.
Okay.
The other person that you can talk to is Dr. Zhao, who Epstein trained, and he's at Mount Sinai in New York. Your doctors, whoever has your slides will know how to send them, and here's his email address. Thank you, Jim Marshall. There's his email address. Again, tell him AnCan sent you. Both these doctors will talk to you about what they find. In fact, they love to talk to you because pathologists are usually locked up in a cave all their life.
Right. I just want to tell you that I find this group absolutely breathtaking, and it's just breathtaking. I can't
Thank
put it into words.
You can fill out the survey that was on there, and you can send us a donation, and we're very appreciative. We hope you come back, and we hope we can guide you to the right treatment. I know in my own case, it did make a huge difference. I am so glad I didn't do the surgery originally, and I had successful treatment with my diagnosis. Your diagnosis is probably somewhat similar. My guess is that you're probably a T3, even though they haven't seen it. That's just my gut.
T3 means what? Metastatic?
Means that that it's locally metastasized.
Okay, got it. Which is still treatable. Which is still treatable, and that you already have that micrometastasis that Egner is discounting. I was guessing that myself from my own.
Well, that would be my gut. I need to get off the call because it's been 3 hours now. Anybody? Oh, Jim Marshall, go ahead.
One question, John. Are you a veteran?
No.
Okay. Thank you.
Okay.
Curious.
So anybody else for anything right now? Or can I go?
Yep.
Thank you. Rick, you're an angel. I really appreciate this.
Oh,
thank you, Rick. Go away.
Pleasure. Yes, Larry Schuler. Larry Schuler, please use the hands up function. Okay?
Yeah.
Don't wave your hands. Don't wave your hands at us. Learn how to use that. It took me a year to teach Dr. Jack how to use the hands up function, and now he's got it. So at the bottom where it says,
there we go. Hey, all right.
Fantastic.
It's
Yes.
It's not always on my screen, so I have to dig for it. I sent John a message, but I'll reiterate it here. If you send your doctor as short as you can make it, summary of your condition before your appointment, it doesn't take time out of the appointment time for him to familiarize himself with your case. So
Great.
I would,
check
with his staff if you can read it.
Very good. Excellent. Thank you, Larry. Great advice.
Great suggestion. And Larry, I don't know if you realize, but our Tuesday meetings start earlier than our Monday meetings. So this meeting started at you're in Alaska, right? Are you on Pacific or what time zone are you in?
1 hour earlier in the day than Pacific time. This is Alaska time.
Alaska.
Okay, so I'm not sure what Alaska. So it doesn't matter where in Alaska is. If you're on the east or the west, it's always the same.
We used to spread across 3 time zones, but now we're just one, and it's 5:08 p.m. here now.
Okay, so you're 2 hours behind me. So this meeting starts for you. Tuesday meetings start for you at 2 o'clock.
2.
Yes.
Oh.
And Wednesday and Monday meetings start for you at 4 o'clock.
Okay, I thought they all started at 4. Okay, thank you.
No. The Tuesday meetings start earlier because the guys many years ago said that the evening meetings went on too late if they were on the East Coast. So when we added two groups on Tuesday, we started them 2 hours earlier. But you can listen. You'll be able to listen to the recording. This will be a long recording. All right. Yep. Good night, everybody. I'm out of here.
Good night.
Good night.
Yep.